Ողջույն հարգելի գործընկերներ,
Hi, dear colleagues. I would like to welcome you on behalf of Armenian Eye Care Project Charitable Foundation, Sergei Milan Eye Center and Department of Ophthalmology of Yerevan State Medical University. And we had an Oculoplastics talk last year. It was so comprehensive that we didn't have enough time to cover the whole material. So we decided to split the meeting into two. So today, again, we're going to listen to Dr. Paul Johnson. And as you remember, it was very interactive, and Doctor was presenting clinical cases. And then we had question and answer session, and participants were sharing their ideas and thoughts on that. So Paul Johnson and Larry Keshishan were presenting also their ideas and their thoughts. I'm sure that today our meeting will be very educational, and I think Dr. Paul Johnson, I think we can continue with whatever was left from the previous meeting.
Thank you, thank you. Good evening to everyone over in Yerevan. Thank you so much for having me here today. I really appreciate it. You could be anywhere in the world today, but you're here learning about oculoplastics, and I'm just grateful for your attention. So thank you so much. So for those of you who weren't present for my first presentation, we did an interactive forum based on the orbital section and then the eyelid section. So basically what we did is we presented a case, and then you guys had the opportunity to pick from a multiple choice poll, and we made it interactive and fun. So last time we did orbit and then half of the eyelid section. So today we're going to do the other half of the eyelid section and then the lacrimal section. And that only leaves aesthetics. So maybe for a future talk, we could do an aesthetics talk. But for today, we're going to focus on eyelids and lacrimal. So we can, whenever you're ready, we can pull up the first case and go from there. Beautiful. So this is a 37-year-old woman, and she's complaining of irritation and pain. So the first question is, what is the diagnosis? Is it ectropion, entropion, blepharospasm, or trichiasis? So you can pick from one of those four options for whichever diagnosis you think it might be. And then the next question is, how can we treat it? So the answer choices are epilation, electrolysis, cryotherapy, or all of the above. So we'll give you a few minutes to pick the diagnosis and the treatment options, and then we'll dive in a little bit deeper. All right, let's go ahead and see what everybody picked. Okay, perfect. So let's see for the first question. It was almost evenly split, but you guys got it. Trichiasis is the correct answer. Entropion is when the eyelid is turning inward and the lashes are rubbing. In this case, the eyelid is in a good position. It's just the lashes that are misbehaving. So for this patient, the correct answer is trichiasis. And then for the second question, you guys got it. It's all of the above, D, all of the above. So typically what I'll do is this patient has a lot of misdirected lashes. So in this case, I would probably do a marginal rotation to get those lashes out of the way. But we can also use epilation if it's just a couple lashes. But usually the lashes will grow back if we simply epilate. So the next step would be to do electrolysis to kill the root of the lashes. And then if that doesn't work, we can do cryotherapy to freeze the lashes. And then cryotherapy, it does usually take multiple rounds of cryotherapy to get the lashes to not grow back. But I always tell patients, like, we will win this in the end. We will get rid of all of the misdirected lashes. It's like a journey. It takes a long time. So, but you guys did great. So I see the slide is up for the next case. So this is a 51-year-old woman who complains that she can't see out of her left eye. She's having trouble seeing. So the first question is, what is the diagnosis? And your answer choices are A, dermatochalasis, B, ptosis, C, brow ptosis, or D, floppy eyelid syndrome? The next question is, which of the following is not a type of ptosis? So A, aponeurotic, B, congenital, C, neurologic, or D, paralytic? So which of those is not a type of ptosis? The next question is, what should we check on her exam? So pupils is letter A, B is extraocular motility, C is fatigability, and D is all of the above. We've got a lot of questions for this one, so it's a good one. The next one is, what measurements should we do? Answer choice A is MRD1. Answer choice B is levator function. That's what LF is. Letter C is Hertel's, which is exophthalmometry. And letter D is A and B, meaning we should check MRD1 and levator function. Question number 5, what testing does insurance require? So this may be different in Armenia, but in the US, basically the answer choices are, do they require external photos? Do they require an OCT? Do they require a visual field? Or do they require ANC, external photos and visual field? And finally, the last question is, how do we repair it? So answer choice A is an external levator resection. Answer choice B is muellerectomy. Answer choice C is frontalis suspension. And answer choice D is it depends on the etiology and levator function. So we'll give you guys a few minutes to pick from those answer choices, and we'll go over each one. This is a great one. All right, let's go ahead and see what everybody picked. Perfect. So you guys got it. So for the first question, what is the diagnosis? The answer is ptosis. She does have a little bit of brow ptosis as well in the photo, but primarily the reason why she can't see is most likely due to the ptosis. So partial credit for those who picked brow ptosis. And number 2, which of the following is not a type of ptosis? So whoever picked paralytic, you got the right answer. So aponeurotic is the most common type of ptosis. That's, if wear and tear throughout the years, basically the levator dehisces in aponeurotic ptosis. Congenital is a type of ptosis. Babies can be born with a droopy eyelid. And then neurologic is also a type of ptosis. Basically, for neurologic cases, patients could have a Horner syndrome or a cranial nerve 3 palsy that can lead to neurologic ptosis. So A, B, and C are all types of ptosis. Paralytic, answer choice D, is not a type of ptosis. So typically what we see with a paralytic situation is lid retraction. So if the facial nerve is paralyzed, the eye will be open too much and will have trouble closing rather than being droopy. Number 3, what should we check on exam? So all of the above, very good. So we're going to want to check pupils to see if there is any signs of a neurologic ptosis, like I said, a Horner syndrome or a cranial nerve 3 palsy. We're going to want to check extraocular motility to look for a cranial nerve 3 palsy. And we're going to want to check fatigability to see if there's any signs of myasthenia gravis. And if there are signs of myasthenia gravis and fatigability, we'll want to get some blood work to rule out that condition. So great job on question 3, all of the above. Number 4, what measurements do we do? And you guys got it. So A and B, we want to check MRD1, which is margin reflex distance 1. So that's going to tell us the distance between the corneal light reflex and the upper lid margin when planning our approach. And then we're also going to want to check levator function to see if the muscle is functioning properly. So it may just be droopy, but it's functioning well, or it could be droopy and it's the muscle itself is not functioning well. And the way that we check this is by holding the brow right here so the patient can't use their brow, asking the patient to look down, and then asking the patient to look up. And I keep a little millimeter ruler there to determine what the levator function would be. And then in the US, maybe the same in Armenia, but basically the insurance company requires external photos and a visual field exam to prove that this is impacting the patient's vision. And for the visual field, basically they will have the patient do the visual field in the normal state, and then they will tape the eyelid up to know if there's any improvement. And hopefully it will show improvement, which would indicate that the patient would benefit from a visual standpoint from the surgery. And then last question you guys got. So letter D, it depends on the etiology and levator function for how we want to repair it. So um, if the patient has aponeurotic ptosis, they have a good levator function, we'll want to do an external levator resection. That's always a good idea. Muellerectomy you can do for that as well. That's just not my preference, but there's plenty of doctors out there who will do a muellerectomy for external levator resection. Muellerectomy I find works really well for patients who have Horner syndrome. And then frontalis suspension can be used in patients who have poor levator function. So because the muscle itself is not functioning properly, if we tighten it, it's still not going to function well. So a frontalis suspension involves recruiting the forehead muscle to help raise the brow as well. Okay, great. So for this patient, this is a 79-year-old man, and he's complaining that he can't see out of either eye. So he's having trouble seeing from both eyes. So let's see what the questions are. So what is the diagnosis? Is it A, dermatochalasis, B, ptosis, C, brow ptosis, or D, floppy eyelid syndrome? The next question, so we only have three questions on this one. So the second question is this cosmetic or medical? So answer choice A if you think that this patient if their surgery would be considered cosmetic, or B, if it would be considered medical. And lastly, number three, how do we repair it? Would we do a lateral tarsal strip? Would we do an external levator resection? Would we do a functional blepharoplasty, or would we use Quickert sutures? So I'll give a few seconds for you guys to pick your best guesses for these answer choices. All right, let's see what you guys picked. Beautiful. So whoever picked for the first question, A, the majority of people got it. It's dermatochalasis. So in this particular case, the eyelid margin itself is in a good position. This patient just has a lot of extra skin that's overhanging and blocking his vision. So the correct diagnosis is dermatochalasis. Quite frequently, ptosis and dermatochalasis coexist, and both conditions need to be addressed at the same time. But in this case, the patient basically just has dermatochalasis, some extra skin there. And would it be considered cosmetic or medical? So in this particular case, it would actually be considered medical because it is impacting his vision. If he just had a little bit of extra skin that wasn't really overhanging and he just didn't like the way it looked, in that case, it would be considered cosmetic and we would have to charge him like an out-of-pocket fee. But because it's impacting his vision, it would be okay to submit this to insurance to see if the insurance would cover it. And likely they would because it looks like it's definitely impacting his vision. And then how do we repair it? Great, you guys, most people got it. The correct answer is answer choice C, functional blepharoplasty. So in this situation, what I would do is make an incision in the upper lid crease. So any scar that forms would be hidden in the crease. And then I would remove the extra skin and fat and sew everything back together. Lateral tarsal strip, I typically use for ectropion or entropion of the lower lid. External levator resection, typically I would use for ptosis. And then Quickert sutures are a type of suture that is used for entropion, where the sutures are placed through the inferior fornix, are passed full thickness through the eyelid and tied externally just underneath the eyelashes to rotate the eyelid out of the way. But in this particular case, because he just has dermatochalasis, functional blepharoplasty is the correct answer. All right. So this is a 45-year-old woman. and she's complaining that her eye is open too much. It's open too wide. So let's go to the questions for this patient. So, what is this condition called? Is this called ectropion? Is this called entropion? Is this called eyelid retraction? Or is this called floppy eyelid syndrome? Number two, what two things can cause it? There's more than two, but in this question, identify two things that could cause it. So the answer choices are thyroid eye disease and facial palsy. Answer choice B is thyroid eye disease and Horner syndrome. Answer choice C is facial palsy and Horner syndrome. And answer choice D is Horner syndrome and myasthenia gravis. And number three, how can we treat this condition? Would we use a functional blepharoplasty? Would we use a gold weight? Or would we use an external levator recession? So not resection, but recession in this case. Or could we use a gold weight or an external levator recession? So answer choice D is both B and C. So I'll give you some time to answer those, and then we'll see how everybody did. All right, let's take a look. Beautiful. So most people got the correct answer for question number one. This is called eyelid retraction or lid retraction when the eye is open too far. And you can see she has what's called scleral show, which means that the white part of the eye is visible, like between the iris and the upper lid, and that should not be visible. So the correct answer is eyelid retraction in this case. What two things can cause it? So most people got the correct answer. Answer choice A, thyroid eye disease and facial palsy are the two most common causes of this condition. Um, and then just looking through the other answer choices, Horner syndrome and myasthenia gravis both cause ptosis. So in this case, thyroid eye disease and facial palsy, again, the correct answers. And then how do we treat it? Both B and C are correct. So a gold weight can be used or an external levator recession can be used. So a gold weight I will typically use in patients who have facial palsy, and then an external levator recession where we go in and we just cut across the levator aponeurosis. That can be done to weaken the muscle, and typically that works best in patients with thyroid eye disease. So for patients with facial palsy, I'll use the gold weight. And then patients with thyroid eye, I typically will do the external levator recession. All right, so the next case, this is a 75-year-old woman, and she's complaining that her eyes spasm all the time. They're twitching all the time. So let's see what her questions are. Great. So what is the diagnosis? Is it A, ptosis? Is it B, dermatochalasis? Is it C, blepharospasm? Or is it D, hemifacial spasm? So first of all, what's the diagnosis? Question number two, how do we treat it? Do we use medical Botox? Do we use a procedure called the Anderson procedure? Do we use ptosis repair? Or do we do A and B, a medical Botox or the Anderson procedure? And number three, what can cause myokymia? Um, so stress is letter A, B, ocular surface disease, C, caffeine, or D, all of the above. And I've been told to go a little bit slower, so we'll give a full minute before we go to answering the question. So take your time and do your best to answer these questions. I'll give you more time on this one. Perfect. So let's go ahead and see the answer choices. Great. So answer choice C is the correct choice. This is called blepharospasm. Hemifacial spasm occurs when the mouth and the whole side of the face is twitching as well. Hemifacial spasm typically is unilateral, whereas blepharospasm is bilateral. Also, hemifacial spasm sometimes can persist during sleep, whereas blepharospasm typically does not persist during sleep. How do we treat it? So you guys got the correct answer there. That's A or B. So we can use medical Botox to treat it, and that's what I use for the majority of my patients. The Anderson procedure, we can also use, this is the procedure where we actually remove some of the overacting orbicularis muscle surgically. So it's done through a blepharoplasty incision, and the offending muscle is removed partially to help with the spasming in these patients. And typically, patients will still need medical Botox after the Anderson procedure, but usually they'll need it a little bit less and hopefully a little bit less often. So that's another option we have for patients. And what can cause myokymia? So myokymia is a little bit different from blepharospasm in that it's just a single eyelid that's twitching. So in this case, all four eyelids are spasming with blepharospasm, but with myokymia, it's a single eyelid. And the correct answer is all of the above. So stress can cause it, ocular surface disease can cause it, and caffeine can cause it. Also, lack of sleep is another thing that can cause myokymia. So when I was studying for my board exam, I had this condition because I was drinking lots of coffee, I wasn't sleeping as much as I should have been, and it was stressful. So myokymia is a distinct condition from blepharospasm. Okay, great. So this is a 79-year-old woman, and she's complaining that her right eye twitches all the time, and so does the right corner of her mouth. So in this case, a little different from the last case, what's the diagnosis? Is this Bell's palsy? Is this blepharospasm? Is this hemifacial spasm? Or is this Meige syndrome? And what do we have to rule out for this person? Do we have to rule out a CVA, which is also known as a stroke, like a cerebrovascular accident? Should we rule out a brain tumor in this patient? Should we rule out a tumor of the parotid gland, or should we rule out carotid stenosis? How many patients with hemifacial spasm have pontine glioma? The answer choices are 1%, 5%, 10%, and 20%. So let's go ahead and I'll give you some time to pick your answers for these three questions. All right, let's go ahead and see. Great. So for answer choice, for question number one, you guys, the majority of people got it correct. Hemifacial spasm is the correct answer. So Bell's palsy, I could see why someone might pick that because it looks like the left upper lid is retracted a little bit, but it's most likely only retracted because the right eye is spasming too much. So this patient is compensating with her left upper lid by trying to raise it open far to compensate for the spasm on the right side. Blepharospasm is not correct because it's only one side that's acting up. Blepharospasm tends to be bilateral. And then Meige syndrome is a condition where it's bilateral and both sides of the face are twitching. So it's kind of like a bilateral hemifacial spasm. What do we have to rule out? So the correct answer is actually answer choice B, a brain tumor. So in hemifacial spasm, very rarely, it can be caused by a type of brain tumor called a pontine glioma. So we always want to rule this out by doing an MRI for the patient prior to starting treatment with Botox, because we definitely don't want to just treat the patient's spasms and miss something that's more serious. And then answer choice C, or question three, how many patients with hemifacial spasm have pontine glioma? Whoever picked answer choice A, 1%, that person is correct. So congratulations, you're the only one who got this one correct. So only 1% of the time do patients have this brain tumor with hemifacial spasm. So it's quite rare. I've actually never diagnosed one, thank goodness, in my patients with hemifacial spasm, but it does exist. So it's always a good idea to have a clean MRI prior to beginning treatment with Botox in these patients. Okay, so that concludes our eyelid section. We're going to now move on to the lacrimal section. And this section is a little bit shorter than the other two. There's just not as much to lacrimal, but we do have some interesting cases to go over. So let's get started. So this patient is a 68-year-old woman who used to have tearing, but she does not anymore. Excuse me. So, which surgery did the patient have? Did she have a repair of a canalicular laceration? B, did she have a DCR or dacryocystorynostomy with Crawford tubes? C, did she have a balloon dacryoplasty with a mini Minoka tube? Or D, did she have cryotherapy? So, which surgery did this patient have based on what you're seeing? I don't know if you can see my mouse, but right here in the medial canthus. And then the other question for this patient is why does she need the tube? So, why is this tube there? Answer choice A, so the tears can drain down. Answer choice B, so the osteotomy doesn't scar shut. Answer choice C, to prevent infection. Or answer choice D, to drain any bleeding from the surgery. So what type of surgery did she have and why does she need the tube? All right, let's go ahead and see what everyone picked for these two questions. Okay, so the correct answer is B, a DCR with Crawford tubes. So this patient underwent tear duct surgery. Um, I don't know the word in Armenian, but it's dacryocystorynostomy, where an incision is either made here, like kind of like medial to the medial canthus, or the incision can be made endoscopically through the nose. So there's two different approaches to this. And a Crawford tube is inserted. So excuse me, so a Crawford tube goes and connects the upper lid and lower lid canaliculi. And the reason, getting to answer choice, or getting to question number two, why is the tube in place, is answer choice B is correct. So the osteotomy doesn't scar shut. So what's done is a little window of bone, a little window in the bone is made to create a detour for the tears to drain down. So the nasolacrimal duct obstruction is typically not able to be punctured through in an adult without it scarring shut again. So we have to create this window in the bone so the tears have a different way to get down into the nose where they're supposed to drain. So this is different from in like a child who has a congenital nasolacrimal duct obstruction where we can usually poke through the obstruction and place the tube. But in an adult, that doesn't tend to lead to success. So we have to make this window in the bone, this osteotomy, and then the tube is placed so that the ostomy doesn't scar shut. Great. So this is an 8-year-old boy. Speaking of children, this is an 8-year-old boy with pain, swelling, and redness. So what is the diagnosis in this case? Is it dacryoadenitis? Is it dacryocystitis? Is it a lacrimal gland, I'm sorry, a lacrimal sac tumor, or is it a lacrimal gland tumor? And number two, what is the treatment? Would this be antibiotics and ice packs? Would we treat it with steroids and ice packs? Would we do antibiotics and warm compresses? Or would we do steroids and warm compresses? So what is the diagnosis? And then what is the treatment? Okay, let's take a look and see what everyone picked for this case. Beautiful. So most people got it. So the correct answer is dacryocystitis, excuse me, which is an infection of the lacrimal sac. So dacryoadenitis would be inflammation or infection of the lacrimal gland, which lives right here, kind of superior and lateral. This is not typically a presentation of a lacrimal sac tumor. A lacrimal sac tumor usually is not as painful, not as red. In this case, dacryocystitis is the correct answer. And then what is the treatment? Answer choice C is correct in this case. So we want to treat it with antibiotics and then warm compresses to get everything to drain. So typically in kids, this treatment with the antibiotics and the warm compresses is enough to resolve the issue. Whereas in adults, they often need it to be drained. So usually these patients do very well with a course of antibiotics and heat. All right, let's go to our next case. Beautiful. So this is a 61-year-old woman, and she has pain, tenderness, and discharge of the left eye. And this Q-tip that you see here is applying pressure to this area. So what is the diagnosis? Is it dacryoadenitis? Is it dacryocystitis? Is it canaliculitis? Or is it a nasolacrimal duct obstruction? So that's the first question. Second question is, what is one possible cause of this condition? Would that be A, topical glaucoma drops, B, Xiidra, which is an eye drop used to treat dry eye? It's an anti-inflammatory eye drop similar to Restasis or cyclosporin. So could that cause this? C, can this be caused by viral conjunctivitis? Or D, a punctal plug? So what would be the cause of this condition? And then finally, number three, what is the treatment? Would we treat this with A, topical antibiotic drops, B, oral antibiotics, C, a canaliculotomy, or D, all of the above? So what is the diagnosis? What is one possible cause? And what is the treatment? So I'll give you guys some time to make your choices. All right, let's see what everyone picked. Great. So for the first question, most people got it. So great. Canaliculitis is the correct answer. Nasolacrimal duct obstruction, you can sometimes see some discharge from the lower lid punctum. However, usually in that case, it wouldn't be, as we went over in the history, it wouldn't have pain and tenderness. So based on the photo, I could see why some people would pick D, but it would not be painful like it is in canaliculitis. Answer choice two, what can cause this? Perfect, you guys got it. So punctal plug is very common. So I've seen punctal plugs cause this quite frequently. I should say not infrequently cause this. So typically, instead of placing punctal plugs, I like to use punctal cautery to shrink the punctum rather than placing a plug in there. Just because I've seen this more than enough times to you know not want to do that. I mean, most people tolerate punctal plugs just fine, but it can cause canaliculitis. Another type of bacteria that can cause canaliculitis is Actinomyces israelii. And in that situation, usually there are some stones that you can actually see in the canaliculus. What is the treatment? The correct treatment is all of the above. So typically what I'll do is start the patient on topical antibiotic drops such as moxifloxacin or and I should say and oral antibiotics such as Bactrim DS, which is trimethoprim sulfamethoxazole. But most patients will need to go on and undergo a canaliculotomy because the topical antibiotics and the oral antibiotics typically will calm the symptoms down, but the symptoms will come back as soon as we get them off of them. So a canaliculotomy is performed. I do this in the office. I numb with lidocaine and then dilate the punctum using a punctal dilator and just make a snip along the lid margin medially to open up the canaliculus, remove any stones or punctal plugs or whatever may be there, and then maintain the patient on the topical and oral antibiotics for about a week or so after. And these patients usually do great, and then they're done, and they're very happy that they have relief from their symptoms. So this next case is our last one, which makes me very sad. We've reached the end. But basically, for this last case, this is a 39-year-old man, and he was attacked by a dog. What is the diagnosis? Is this an eyelid laceration? Is this a nasolacrimal duct obstruction? Is this an orbital fracture? Or is this a canalicular laceration? So eyelid laceration, nasolacrimal duct obstruction, orbital fracture, or canalicular laceration. And then how do we repair it? So should we suture this directly closed? Should we use to seal glue? Should we place a mini Minoka tube and then suture it closed? Or should we place an orbital implant? So I'll give you some time to answer these questions. What is the diagnosis and how do we repair it? Perfect. So the correct answer is D, canalicular laceration, but I'll give partial credit to A because this is an eyelid laceration as well. So you can see that the eyelid is lacerated, but the canaliculus has also been lacerated. And so whoever got D, you get full credit, and answer choice A, partial credit. And then how do we repair it? So the correct answer is answer choice C, place a mini Minoka tube and then suture it closed. So what we want to do is place a mini Minoka tube through the punctum. And then what we have to do is find the medial cut end of the canaliculus, which is not easy. I've done more than my fair share of these when I used to take trauma call, and I remember being up in the middle of the night searching for this medial cut end. But when we find it, it's always very satisfying because we'll then feed the mini Minoka tube through the medial cut end of the canaliculus to stent it and protect it. And then what we can do is repair the eyelid laceration around it. So once we have stented the canaliculus, we can then go ahead and suture the eyelid around it so that the patient does not have postoperative epiphora. So thank you for your attention. I'll answer any questions that you might have at this point.
Hi, dear Paul, and hi to everyone. Thank you very much for this nice presentation. Dr. Paul, I should like to do some comments regarding the cases that you nicely presented. Actually, regarding the lacrimal system diseases, the dacryocystitis we see very commonly in Armenia. Unfortunately, it is very often disease that we can see in our practice, and usually we do an external DCR. I should like to. I have a question to you. Do you what kind of surgery do you usually do? Is it external DCR or endonasal endoscopic DCR?
So, a great question. So, I typically do an external DCR just because the success rates tend to be somewhat higher with the external DCR. Typically, I think they say the success rates for external DCR are about 95%, and then for endoscopic DCRs are between 85 and 90%. So, if the patient is not concerned about having a scar, typically I'll do an external DCR for those patients.
Yes, thank you very much. The same we do. And usually, how long do you leave the stent? Usually, I leave it there for 3 months, and then after that, I remove it. Do you leave it longer, or you also leave it for 3 months?
Yep, right on the money. I do 3 months as well. So we're exactly the same in that regard. Usually 3 months, and then I remove it in the office afterwards.
Yes, thank you very much. And regarding the CDCR, after 2020, very often we see blepharitis that ends with canaliculitis, and that brings to bicanalicular obstruction. And unfortunately, I don't used to do CDCR. Actually, I have never done it, but I hope that you will plan to travel to Armenia, and if you are doing that surgery, the CDCR, I wish to be able to do that with you in Armenia, and then maybe I will continue it myself. What about that plans?
No, that sounds great. I've actually only done two of them in my whole life, so I'm definitely not an expert on CDCR, but my patients who I have done them on have really noted improvement in the tearing. So it is a great surgery.
Yes, thank you. So maybe we will have chance to do it together. And
That would be great.
regarding the canaliculitis, we also very often see canaliculitis, and very often we find out dacryoleads. Usually, when we see pus in the canaliculus and during the surgery, very often we remove dacryoleads. Regarding the stones in the lacrimal sac, I have seen only twice, but during 1 year, usually we see canaliculitis, maybe 5-6 cases during the year, and we often find out their dacryoleads. What about your practice? Do you also usually see dacryoleads while doing canaliculotomy for the canaliculitis?
Yes, very commonly. So typically what I'll do is remove them using a curette, and then I send them to the lab for culture. And usually what will come back is actinomyces as the bacteria that cause the dacryolis. So very commonly I do see them, and then I go ahead and culture them.
Yes, the same we do here, and I usually like to prescribe after the surgery steroid with antibiotic, maybe something like Tobradex for 3 weeks.
Perfect. Perfect. Yeah, I think that would work great.
Thank you. And then regarding the ptosis surgeries, I usually do in my practice external approach of levator reattachment for the acquired senile ptosis, and for the congenital, again, external levator resection surgery. I don't used to do the internal type of surgery. You said also that or you also don't do so much the internal transconjunctival. Do you do so?
I do some, sometimes like for patients who have Horner syndrome. I will use the internal approach. I find that it gives them a good result because they usually only have about 2 millimeters of ptosis. So I find the internal approach works great for those patients. Um, but there are lots of docs in the US who will do the internal approach as their standard approach. Um, and that works well for them. For me, I like having the ability to adjust the eyelids if I have to, because we all know that with ptosis surgery, it's not uncommon to have asymmetry afterwards. So with the external levator resection, I'll place multiple 6-0 nylon spurs from the tarsus to the levator. And then if one lid is higher than the other, in the office, I'll go ahead and remove one of those stitches to help even things out in the first week or two after surgery.
So do you do that kind of procedure on the third day, or
Within
you wait longer?
usually within the first week. The first day or two, they're still pretty swollen, so it's hard to tell, where they're going to land. But after that, you can kind of tell if one lid is higher than the other. So between 2 and 7 days, I would do that adjustment in the office.
Yes, actually, for me in my practice, congenital ptosis surgery, uh, when the levator function is more than 4 millimeters. So if I'm not going to do a sling surgery, the levator resection actually. Maybe I'm not very satisfied with the results. Sometimes it is very difficult to bring very close height of the lid when from the other side we have normal, and even sometimes we have large. Do you have any points that you like to do it to have better results for congenital types with levator resection?
Yeah, so if the levator function is better than 4, like you mentioned, I'll do what I call a maximal resection. So I'll go in and really resect that muscle as much as I can to try to get the lid up as high as I can.
Do you go
Uh,
to Whitnell's, like above the Whitnell's ligament?
Right up to Whitnall's ligament. Yes, yes, exactly. And so I like that approach because it doesn't involve placing like a foreign implant in the eyelid, which is nice. But if the levator function is 4 or less, then I'll go ahead and just do a frontalis suspension because I know that no matter how much I resect the levator muscle, it's not going to really fix the problem. So.
Yeah, so I used to use the FCI frontalis sling, the tarsofrontal suspension set, the FCI French.
Okay. Yes, yes. Perfect.
And
Yeah.
the other case regarding the mini monocle for the lacerated canaliculus, actually, I leave again it for 3 months. Do you also leave it for 3 months, the mini monocle for the lacerated
Yes.
eyelid margin?
Yep, 3 months. So I don't really do much trauma work anymore, but when I used
Mhm.
to, I did leave it in for 3 months because I feel like that was the perfect amount of time to allow everything to kind of heal. And then those are very easy, like to just remove in the office, and patients did great.
So thank you so much also for this discussion. I hope that you will be able to travel to Armenia because I would like to do with you some kind of surgery that are much more problematic, that is congenital ptosis, that is CDCR cases. And so I hope that you can find some time for September to join the AECP members travel to Armenia. It will be great to have chance to work with you, to see your consults, and also to be able to do surgery with you. Thank you very, very much.
Thank you. Thank you so much.
We have still several minutes, and I was wondering if there are any questions that you would like to ask about the development of ophthalmology in Armenia or something that relates to oculoplastics.
Yeah, I guess the next step, if we wanted to, we could do an aesthetics talk. I'm just curious to know, in Armenia, if Botox and fillers are available, and if so, which ones is that something that's commonly done, or because that's a big part of my practice as well.
Yeah.
So
So, well,
I can answer to this question. Actually, we are doing Botox injections for the hemifacial spasm, for the essential blepharoplasty, and also for the aesthetic part of the surgical types, that is blepharoplastic surgery. So we used to do that kind of surgery, not as much as the other part of the surgical types, but also we do that. There is a big problem that the allergan, there is no representative in Armenia of allergan. That is why we are using botulinum toxin A from the other groups. So the strongly Botox we don't have in Armenia, as there is no allergan in Armenia, but we are using other types of botulinum toxin A.
Understood, understood. And do you guys do dermal filler injections as well?
Not so much, very, very seldom.
Gotcha, gotcha.
but actually, in continuation to what Dr. Johnson said, would you be interested to have a grand round session on aesthetic surgery, or does that
I
not
think that will be
feel
great to have
into
a
what you're
chance to
doing?
have this kind of lecture. That will be great.
Hmm.
Perfect.
So wonderful. So we have our next step. We know what to expect from you. If you could just give us, certainly we don't want to put that much pressure on you. We're very thankful to these two wonderful sessions. Whenever you have time during the year, we would be more than happy to schedule it and have it.
Beautiful. Yeah, that's a fun talk. So I think that would be great.
Wonderful. So if we are here on this very optimistic note, I would like to thank everyone. Special thanks to you, Paul, and certainly to Dr. Varakeshishan, as well as Tamar and Olanes, who have orchestrated the grand round in this very new fashion. And thank you. We have never done that. So we will look into doing that, as Armenia was saying. It's very useful for clinical residents as well. And then we'll go forward with that. Thank you very much.
Thank you.
Thank you
Thank you
very
for having
much.
me.
Bye bye.
Bye.
Bye bye.
Bye.